Okay, everyone, here we go. Module 9F for sepsis. These are several terms. At this point, I believe you know these terms. I'm just going to review them anyway, because it's important to have an understanding of these terms when you start talking about sepsis. And then our next unit right behind this is septic shock. And hopefully as we go through all these things, you'll understand why I put things in the order they did. Bacteremia, bacteria, or toxins in the blood. Septicemia is a pathogens in the blood, because septicemia may be not just bacteria, as in bacteremia. Pathogens can be a bacteria, a virus, a fungus. So that's where it's pathogens, things that are bad for us, toxins. Okay, so sepsis is SIRS resulting from an infection. SIRS is systemic inflammatory response syndrome. I am going to be breaking these down a little more. I just want these terms familiar in your head as we start to progress through. So the body's response to a critical illness that can result from an infectious or non-infectious cause. We've talked about DIC, which we're going to mention again in sepsis, because the whole body starts to respond. It becomes a systemic, not just a localized response, but a systemic whole body response, and the body responds with inflammation. Severe sepsis is sepsis with acute associated organ failure. As we go through sepsis, you will see you can have sepsis progress from mild and further as different organs or one organ or multiple organs are involved. Septic shock, persistent low mean arterial blood pressure, result of overwhelming infection despite adequate fluid resuscitation. A lot of words will make sense by the time you are through with this unit. To put you at ease, you know what your mean arterial pressure is, your MAP. Some things say you need a mean arterial pressure of 60, probably look at 65. Your mean arterial pressure. Remember the formula for mean arterial pressure is your systolic blood pressure plus 2 times your diastolic pressure divided by 3. Simply, systolic, as we just learned, is when the ventricles are in systole, when they are squeezing and blood is pumping from the right ventricle to the lungs, from the left ventricle to the body. So when your cardiac output is at its max, the blood is going out, that is your systolic. Your diastolic is when it is at rest, your bottom number, lower number. And then divide by 3, because you have 3 total numbers in there, and that gives you your mean pressure, your average pressure in the body, which is indicative of your volume load that can be circulated. Okay, let me keep moving here. Oh, see, if you're talking about your volume and you're giving fluid resuscitation, and even with fluid resuscitation, that mean arterial pressure is still below that 60-65 range, you are considered in septic shock. Refractory is no matter what you're doing. We'll talk about vasopressor drugs. We'll talk about all these fluid resuscitation. So no matter what you're doing, it's refractory. It is fighting. It is not responding. So here, definition of sepsis, the body's inflammatory response to microorganisms in the blood or other tissue, potentially leading to malfunctioning of organs, shock, and death. So any of those is sepsis. You don't have to be in shock to be septic. Talked about it being SIRS resulting from an infection, that is sepsis, the systemic reaction of inflammation. It is an uncontrolled host response. It's a host response induced by the microbials or pathogens that have invaded the body, and the neutrophils start to fail in the infection sites. It is a leading cause of death for non-heart related ICU admissions, 11th leading cause of death in the United States, which is significant. It can occur as a complication of any infection of any body tissue that a pathogen enters and then comes into the bloodstream, then starts traveling to other tissue. Pathophysiology, I broke down in page 636, 637, a lot of information. I am trying to break it down into understandable pieces for you. I'm not going to read the slide to you, I'm just going to expand on it. So endotoxins are found in the wall of the bacteria. And when the cell is disrupted from this endotoxin, these endotoxins from the bacteria are released. That leads our body to have a fever, the inflammation, and the inflammation leads to clotting, bleeding, as we talked about in DIC, hypotension because the vasodilation and all the body responds, and may also cause your body to release enzymes, which will make sense when we talk about what labs you do. So the body responds with the neutrophils, and they come to that area of infection, and they form something called NETs, N-E-T-S, which is neutrophil traps. These traps trap the pathogen. And how much this infection is controlled initially without becoming a septic situation depends on how efficient these neutrophils are in getting in there and killing the microbes. It's called microcytal activity. So can they get in there and do that? Unfortunately, in the sepsis, the neutrophils don't work appropriately. So these nets that trap it end up with a systemic activation of the neutrophils, and the nets go into the blood vessels. They start to cause endothelial damage in those blood vessels. They start migrating throughout the body in this septic situation. Now, I'm not going to be crazy asking too many of these questions like this. I just want you to understand, again, the pathophysiology behind it, and so you can understand how the patient will present, how you will manage their care. Oh, here we go. I forgot I had put this slide in here talking more about the role of the neutrophils. Neutrophils are most abundant cell type involved in our natural immune response. They're rapidly recruited to the site of injury or affection where they engulf, they just suck up that microbe. There's a neutrophil apoptosis, A-P-O-P-T-O-S-I-S, apoptosis. That's a programmed cell death that prevents that neutrophil from releasing its toxic contents, so that neutrophil doesn't spread those toxins throughout the body and cause all this damage. Unfortunately, in sepsis, this apoptosis, or this natural killing off of those neutrophils, doesn't happen. It fails. So those toxins get released from these nets into the whole body and cause the whole septic process that leads to DIC and shock. Okay, hopefully that piece has prepared you to talk about sepsis. They have SIRS, which is the inflammatory response. That's the precursor to sepsis. SIRS is not sepsis, but it is this systemic inflammatory reaction of the body that is triggered by the infection. You can see I like this little slide, that's why I put this picture in here. Heart rate's a little up, white blood count's up, There's some bands, those are your immature white blood cells, meaning, okay, the body is trying to fight this. It doesn't have enough to fight it with, so those immature white blood cells are having to kick in. They're starting to breathe a little too fast, so they're blowing off their CO2. Their temperatures possibly elevated, not that significant yet, but it also can be hypothermic, especially in the elderly or something. The heart rate's starting to go up, so the body is getting this thing and it's all inflammatory and it's trying to fight. It spreads into sepsis, where the infection is in the body. Then it becomes more severe, where there's some end organ damage, where some organ, whether it be the kidneys, the lungs, something is affected by this. They've so vasodilated that they're hypotensive, their mean arterial pressure has dropped. Lactate is going up, which means there starts to be some muscle death from this infection. Then leads into shock, where more significant end organ damage. The severe sepsis has persisted, and they're getting in a shock state. In septic shock, there's critical reduction in the tissue perfusion. They have very acute failure of multiple organs, including the lungs, kidneys, and liver, possibly. So, do you need to distinguish between all these steps? No. Again, it is an understanding of the septic process. Okay, so etiology begins with septicemia, begins with that bacteria that's in the bloodstream, or not bacteria, sorry, toxin, bacteria, virus, or fungus in the bloodstream that starts to spread through the whole body systems. I just have in the background here, does your patient really need a catheter? There's so many things out there now. There are bundles for ventilator assisted. Oh God, I can't even think what they're called. It's ventilator associated pneumonia. So they have bundles to prevent pneumonia due to intubation, patients being on ventilators. There's CAUTI bundles, catheter-associated urinary tract infections that can lead to sepsis. So there are multiple bundles out there. Often nursing are on the front line of developing these bundles for protection, because the goal is to stop sepsis. If you remember going to the sepsis awareness at Motlow, where they talked about these things. So portal of entry, the bacteria, virus, or fungus has to have an entry port, whether it's urinary, respiratory, GI, through the skin, female reproductive system. There's 60% mortality related to sepsis, even though we're treating it. So how can they get urinary catheters, suprapubic catheters, cystoscopies, anything invasive into that system? Respiratory, it can be an aspiration pneumonia. It can come from suctioning. It can come through a trach, because that's an open, we've broken that natural barrier. Endotracheal tubes, ventilators. In our GI tract, peptic ulcers, ruptured appendix, peritonitis. Our skin, it can be through our IV sites, arterial lines, invasive monitoring through our CVP, central lines, PICC lines, Swan-Ganz catheters. It can come from pressure ulcers, surgical wounds, any kind of trauma that broke our skin barrier. Female reproductive, ascending infections that starting in the vagina and travel up, such as sexually transmitted infections, tampon use, different procedures that go into the vagina, into the uterus, like elective surgical abortions. I had a patient years ago, young, she was only 16, was pregnant, had a C-section, and ended up with MRSA in her uterus post C-section. Okay, Risk factors. People that are hospitalized, debilitated, chronic illness, poor nutrition, invasive line surgery, older adults, immunocompromised, improper tampon use such as toxic shock syndrome. Toxic shock syndrome, I was actually, I want to say my 20s when they first identified toxic shock syndrome from using tampons, but it was related more to this super tampons after they came out, but it's very, very virulent infection. So prevention, that's our job. Watching for early signs of sepsis, immunization against organisms that cause pneumonia like the pneumococcal vaccine, influenza vaccine, aseptic technique, good hand hygiene, just being aware, especially if somebody is more immunocompromised, and of all times with this COVID-19 out there, to be very aware of prevention. Clinical manifestations: fever or hypothermia, tachycardia, tachypnea, diaphoresis. Hypotension, it's not a late sign, it's just not always present initially because first the body starts to vasodilate because of this inflammatory stuff that is released, and the body vasodilates. Initially, with the vasodilation, the ventricles are pumping against a lot less pressure because the pulmonary vascular resistance, the systemic vascular resistance, or PVR, SVR, those are decreased because the dilation, so the cardiac output initially is increased. So initially the blood pressure doesn't drop, but that doesn't last because then they go into that hypotension. So even though I wrote on here later, I don't mean late. It just is not always hypotensive from the very beginning because of very temporary increase in cardiac output that soon drops. So hypertension is in there in your clinical manifestation. Signs and symptoms of sepsis may be subtle because it can look like other things, like delirium. It might look like they have a cardiac problem, a cardiac dysfunction such as heart failure or heart attack. It might look like a pulmonary embolism because the symptoms, especially if they're post-op and you're looking for these other things, may miss the very, very early signs of sepsis. When they get hypotensive, that is a bad sign because that's when that cardiac output is dropping. Okay, even prior to the blood pressure dropping, even if the blood flow is initially increased with the increased cardiac output, there still isn't that good exchange happening at the capillary level, so they are in trouble. So, sepsis in an older adult, they are higher risk for getting into a septic shock because their compensatory responses may be very limited. Also, those with any reason for suppressed immune system, immunocompromised in any way. Okay, so early and late phases. Early, what they call the warm phase versus the later or cold phase. Initially, I talked about this vasodilation that will then start to lead to hypotension and fluid shifts. So with this fluid shifts and the septicemia and the high fever, they're very flushed. These arteries and arterioles are dilated, so that's why they get in the flushed skin. And that initial increase in cardiac output before it clamps down, and even when it starts to clamp down, before they get really into the shock phase. The goal is to attack it during this early septic shock with blood draws, infectious disease, respiratory therapists, pulmonologists, whether it be gerontologists, pediatricians, anyone specializing for whatever age group is affected. So your cold phase, of course, is the hypovolemic. There's not enough volume going around. Their body is compensating by trying to clamp down or trying to dilate more. It's doing everything. Urine is getting down to nothing or minimal. They're shunting blood to the vital center organs, and so And because of the clamp down, their periphery is getting cold because everything is shunting to central. So their periphery is getting cold. Diagnostic tests. CBC, you're looking at your white blood count. You're looking for bands, immature white blood cells. You're looking at your H&H, hemoglobin and hematocrit. Those levels may go up for a couple of reasons. They can be falsely elevated because they're actually dehydrated, so they're volume depleted, so you have a false elevation. Also, they can be more concentrated because, with that leaking, vascular leaking. Now, your white blood count can be elevated and it also can drop. So you might see the initial elevation, but as those white blood cells and neutrophils are not working right, they start to get destroyed. So you may actually see that lack of immune response and no more white blood cells to work. So you might have at some point a lower count. Blood gases, arterial blood gases. You're going to see them turn into an acidotic state because the body's trying to compensate for this low oxygen that is going through because perfusion isn't working. Your renal function, your BUN and creatinine, they're going to elevate, especially your creatinine. Your specific gravity in your urine may increase because there's less going out and your body's trying to hold on to it. Serum enzymes, your lactate because of acid production, CKs and later, especially if it's attacking the muscles, especially in your kidneys when they're in shock, you might see some liver enzymes going up as the liver capillaries are damaged. Hemodynamic monitoring, looking at your arterial pressures, your systemic pressures, your cardiovascular output, chest x-ray, EKGs, CAT scans, MRIs, depending on the symptoms, the source, and what you need to assess. Pharmacology. No, I'm not going to ask you on this test. NCLEX will ask you. There may be questions on your final. I haven't gotten that far yet, but definitely NCLEX because you guys are at the end. Broad spectrum antimicrobials. You don't want something that's only going to work in the bladder. You don't want something that's only going to kill a certain type of bug. You want broad spectrum that'll kill a variety of bugs, of bacteria, microbes. Fluid replacement. A preference is isotonic. Normal saline, 0.9% saline is what you will see used the most. You may see albumin because it's like to expand some of the volume. So you're looking at your crystalloid and your colloid. Crystalloid, colloid. Colloids are more concentrated. Albumin will commonly be used. There's also your especially like we talked about with DIC, you may see blood products, cryoprecipitates, a plasma, other things being given. Oxygen therapy. Anybody in sepsis requires supplemental oxygen. Anyone. They may reach the point where they have to be intubated, which is what we're seeing with this COVID-19 because it's a SARS. It's severe acute respiratory syndrome causing multiple infiltrates in the lungs leading to ARDS and intubation. Vasopressors, vasodilation, inotropics, you're going to see dobutamine and dopamine usually initially, and then for your inotropic effect and vasodilation because you want the vessel's periphery that has clamped down to open up so it can be perfused, and you want the heart to squeeze, have an inotropic effect. This can then later need more vasopressors to shunt again to the central with your epinephrine and Levophed, and I mentioned these in your shock lectures too. And you definitely need at least 2 large bore IV access. You need good access to get in massive amounts of fluid. What is your assessment? Continuous monitoring of their vital signs. Hemodynamic monitoring, which I mentioned, focusing your assessment for ventilation, perfusion, renal function. You know what that means. You want to watch their respiratory rate, their lung sounds, their mentation, their cardiac output, their pulse strength, their skin color, their urine output, strict INO. Okay. So, a diagnosis. Nursing diagnosis, what are you looking for? They have a risk for shock, unless they're already in shock. Initially, if they're septic, they're at risk for shock. They have an impaired gas exchange. If they're septic, they have an impaired gas exchange. That's why supplement in O2. Risk for ineffective renal perfusion. That's if it has not affected their kidneys yet. With a decreased perfusion, they are going to have decreased perfusion to their kidneys. Ineffective peripheral tissue perfusion. That is a given, whether they're vasodilated, because they are going to vasoconstrict. So impaired tissue perfusion, peripheral tissue perfusion out to their extremities is a given. Risk for a ballast fluid volume. That is really, really high risk. That's why you're doing fluid resuscitation. Planning goals. What are you looking at? What do you need to keep in mind when you're planning for this patient? Keeping their O2 saturation above 90%, doing blood gases, and watching their PO2 level. AO2, their arterial levels. Maintain adequate renal perfusion. You want your urine output at least 30 mils an hour, or you want to make sure, remember, 30 an hour is the general rule. The more specific is 1.5 to 2 milliliters per kilogram per hour on NCLEX. Depends on how they ask it. If they don't give you that person's weight, whether it's in pounds or kilograms, they're looking for the general 30 mils an hour. If they give you somewhere in there your weight, whether it's pounds or kilograms, make sure you calculate it out and get the best answer. 1.5 to 2 mils per kilogram per hour. Your mean arterial pressure. Over here on your responsive fluid resuscitation. Mean arterial pressure, 60 to 65. I said some things will read 60, some will read 65. I can't see NCLEX trying to trick you on that. Mean arterial pressure calculation. Your systolic blood pressure plus 2 times your diastolic blood pressure divided by 3 is your mean arterial pressure. Okay, so implementation. What do you need to do as a nurse to address these things? You're monitoring your skin, cardiopulmonary function, fluid status, renal function, body temperature, change in mental status. Everything we've been talking about. Looking at skin color, temperature, turgor, moisture. Cardiopulmonary, you're looking at blood pressure, rate and depth of respirations, lung sounds, pulse ox, peripheral pulses. Your fluid status, you're looking at the for jugular vein distension, or you're looking at your central venous pressures, you're looking at your urine output, your intake and output, watching their body temperature, whether they're hypothermic, hyperthermic. If you have a Foley catheter in, you're doing hourly urine measures. You're assessing their mentation, their level of consciousness, and how do you evaluate this? You'll want to make sure you're monitoring for adequate oxygenation, renal perfusion. These are what your goals were, so that's what you're evaluating. Their blood pressure and perfusion may respond to fluids unless they get refractory. As fluid leaves the intravascular space, and because they start to third space that goes out into, because the vessels are leaking, so they decline. As perfusion declines, their renal, cardiac, pulmonary, and neurovascular status will change very rapidly. And that is the end of my recording for your sepsis lecture.